If L-Arginine were just a nitric oxide switch you flip before training, the evidence would look cleaner than it does. The amino acid is real, the pathway is real, and the marketing is loud. We need a careful map from arginine to nitric oxide to blood flow markers, then to outcomes people actually care about: pumps, performance, wounds, and heart risk, without letting a bottle label do the science.
Then why do so many videos sell arginine as the secret to unstoppable performance? Is a temporary pump the same thing as better training results? Or are those two completely different promises dressed up as one supplement?
Start with the physiology. Endothelial nitric oxide synthase can use L-Arginine to make nitric oxide, a signaling gas that helps blood vessels relax. That is why arginine shows up in every nitric oxide booster pitch. But production depends on enzyme activity, cofactors, and competing inhibitors, not only how many grams are in the scoop. There's also a brake on the system called asymmetric dimethylarginine, or ADMA. ADMA can inhibit nitric oxide synthase, so the arginine story is partly about whether the pathway is blocked. In people with atherosclerotic lower limb ischemia, that ADMA nitric oxide axis is a concrete research target, not a vague wellness vibe from Fitness Short.
So if ADMA is the brake, does taking more arginine just overwhelm it? Or is that the oversimplified version fitness channels repeat in 60 seconds?
A randomized, placebo-controlled trial in atherosclerotic lower limb ischemia used about 6 grams of oral L-Arginine daily for 2 months. ADMA fell in people with hypercholesterolemia by 30 and 60 days, and in mixed hyperlipidemia by 60 days. Homocysteine did not change significantly. That is a biomarker signal in a diseased vascular baseline, not a medal for healthy gym goers chasing a pump.
Wait, so the same arginine dose helped ADMA in high cholesterol or mixed lipids, but not in isolated high triglycerides? Does that mean my blood lipid pattern could decide whether this supplement even moves the needle?
Now, put the gym and gaming claims beside that. A 2025 systematic review of nutritional supplements in esports found most protocols were caffeine-based. Arginine showed up mainly as a inositol-enhanced arginine silicate among mixed formulas. Signals for attention or shooting metrics were preliminary, heterogeneous, often small sample, and not a clean arginine victory lap for nitric oxide boosters. So who is the better fit conversation? People with impaired endothelial signaling or atherosclerosis-related limb ischemia are closer to the studied biology than a well-perfused recreational lifter chasing a pump. Food-first arginine from protein foods is ordinary nutrition. Concentrated grams are a different exposure and need a different evidence bar.
How should someone think about chicken, dairy, or legumes versus a 6-gram powder? Is food arginine basically the safe default and supplements only a targeted tool when a clinician has a reason?
Hospital nutrition is another lane entirely. In colorectal cancer surgery reviews, combined immunonutrients, arginine with omega-3 fatty acids and nucleotides were linked to fewer post-operative complications, especially wound infections. Isolated single nutrient tricks did not look helpful. That is a formula story, not proof that arginine alone heals every cut at home.
Hold on, if arginine can change vessel signaling, what about people on blood pressure drugs or nitrates, or anyone who already had a heart attack? That feels like the part glossy benefit lists skip.
Exactly. Dietary supplements can interact with medications and raise risk when medical problems are already present. For arginine, treat blood pressure therapy, nitrate medicines, recent heart attack, and significant kidney disease as clinician checkpoints, not internet self-triage. A store label is not pre-market proof that a concentrated dose is safe for your regimen.
What about pressure injuries or recovery drinks after big operations? Those ads make arginine sound like wound insurance. Did the newer trials actually clear that bar, or are we still stuck in hopeful trends?
A multi-center randomized trial around radical cystectomy found specialized perioperative immunonutrition with added L-Arginine, omega-3s, and nucleotides did not reduce 30-day complications versus standard oral nutrition. And a meta-analysis of arginine-enriched enteral nutrition in critical illness did not show infection or other clear outcome benefits. Mechanism can look elegant while the primary clinical scoreboard stays flat. Pregnancy research adds another nuance. A network meta-analysis of supplements for preventing preeclampsia found an L-Arginine plus bivitamin plus vitamin C and E combination among the better-looking options versus placebo. That is combination evidence under obstetric supervision, not a green light for unsupervised high-dose arginine in pregnancy.
I also hear herpes recurrence warnings and kidney caution in the same breath as 10 benefit listicles. Which of those are real decision points, and which are just scare seasoning around an amino acid found in food?
Keep it proportional. Ordinary food protein is not the hazard frame. Concentrated arginine is where adverse effects, blood pressure interactions, herpes recurrence concerns, kidney limitations, and pregnancy decisions matter. Supplements also vary by product quality compared with study materials, so identical label claims are not identical evidence.
If someone and their clinician still choose a trial, how do you judge whether arginine is helping without falling for a temporary pump? What should change your expectations after a few weeks?
Use 3 layers. Biomarkers like ADMA can move without you feeling different. Symptoms like pump or warmer hands are noisy. Clinical outcomes, fewer complications, better walking, or a supervised preeclampsia protocol are the expensive answers. Arginine's record is strongest when you keep those layers honest and refuse to let a biomarker cosplay as a performance trophy. The fair takeaway is narrow. L-Arginine can matter in nitric oxide chemistry and sometimes shift vascular biomarkers in the right disease context. Performance and broad recovery claims stay inconsistent. Immunonutrition results are formula-specific and often null on primary endpoints. Food is ordinary. High-dose powders are a medical conversation, especially around heart drugs, nitrates, kidneys, herpes history, and pregnancy.